Hi everyone, and welcome to this video on the arterial blood gas. By the end of the video, you'll know what each component of the ABG means, and you'll know how to interpret the results to come up with a diagnosis. The arterial blood gas is a really useful investigation as the results are available within a couple of minutes after taking the blood sample. This is because it can be run on an automated machine by the sample taker. The results therefore give you a near immediate reflection of the patient's clinical state. The ABG will produce a lot of useful results, but for the sake of this video, we're going to focus on acid balance, oxygen, and carbon dioxide, since these results are unique to the ABG. To interpret the ABG results, it's best to stick to a systematic structure, looking at one result at a time. Firstly, we need to assess pH. A pH less than 7.35 means the blood is more acidic than it should be, whilst pH above 7.45 means it's alkalotic. The blood pH in healthy individuals is kept under tight control, since the range of metabolic reactions happening in our body rely on a specific concentration of hydrogen ions. pH is controlled in three ways. Chemically, using buffers like bicarbonate and phosphate, via the respiratory system, where changes to ventilation rate can alter the amount of carbon dioxide and thus carbonic acid in our blood, and via the kidneys, through retention and excretion of acidic hydrogen ions versus alkalotic bicarbonate. A small change in pH actually reflects a large change in hydrogen ions, since pH is on a logarithmic scale. The second result to check is oxygen, which is measured in kilopascals, a unit of pressure. Oxygen under 10 kilopascals means the patient is hypoxic, and under 8 is called respiratory failure. In other words, the gaseous exchange in the lungs is not efficient enough to meet the demands of the body. Respiratory failure is a really worrying sign and can happen in severe lung conditions. Respiratory failure can be subcategorized into two types. This is an important distinction as it changes the management for the patient, as I'll come on to shortly. Type 1 respiratory failure occurs when oxygen is below 8 kilopascals, but carbon dioxide remains normal. This is due to a mismatch between ventilation and perfusion in the lungs, also known as a VQ mismatch. Most commonly, we see it caused by pneumonia, pulmonary emboli, pulmonary edema, or in asthma attacks. In fact, normal carbon dioxide levels in an asthma attack is a worrying sign that the patient is in a life-threatening condition. Type 2 respiratory failure occurs when oxygen is less than 8 kilopascals and carbon dioxide is high. This happens in conditions such as COPD, pulmonary fibrosis, neuromuscular conditions such as motor neuron disease, and obesity. Type 1 respiratory failure often requires treatment with CPAP, whereas type 2 respiratory failure will often require BiPAP to help with ventilation and remove the excess carbon dioxide. When assessing oxygen pressure in the blood, it's important to take into account the patient's fraction of inhaled oxygen, i.e., what percentage oxygen are they breathing in. Room air contains 21% oxygen, and our arterial blood should contain around 11 kilopascals of oxygen. The difference between 21% oxygen and 11 kilopascals is 10, and we can use this difference of 10 as a general rule. For example, if a patient is inhaling 28% oxygen via a Venturi mask, we would expect their PO2 to be roughly 18 kilopascals. However, be aware that this is not a precise rule, particularly when inhaling high percentages of oxygen. For example, high flow oxygen can be up to 70%, but it's rare to be able to get PO2 past 30 kilopascals. Thirdly, we need to check the pressure of carbon dioxide, also measured in kilopascals. We can think of carbon dioxide as being an acidic gas, since when dissolved in the blood, it forms carbonic acid, which will release hydrogen ions. Respiratory acidosis occurs when the blood pH is low as a result of high carbon dioxide. This happens in the same conditions that cause type 2 respiratory failure, i.e., it's a ventilation problem. In respiratory acidosis, bicarbonate levels will either be normal or high as a compensatory mechanism by the body to help increase the blood pH. In either case, the bicarbonate is not contributing to the acidosis. When the bicarbonate is raised to try and reduce the respiratory acidosis, we call this partial compensation. If the bicarbonate was raised enough to a level that normalized the respiratory acidosis, we would call this complete compensation. Respiratory alkalosis occurs when an individual hyperventilates. This results in the lungs removing excessive carbon dioxide from the blood, which increases the pH. There are numerous reasons why an individual may hyperventilate. For example, if they're in pain, having a panic attack, during an asthma exacerbation, or if they have a pulmonary embolus. In this condition, bicarbonate will either be normal or low as a compensatory mechanism. After carbon dioxide, we then need to properly assess the bicarbonate. Metabolic acidosis differs to respiratory acidosis in the cause of the low pH. In metabolic acidosis, the low pH is a result of low bicarbonate. Bicarbonate is an alkaline buffer, so when it's low, the pH will also be low. In these cases, the pressure of carbon dioxide will either be normal or low as a compensatory mechanism. Metabolic acidosis can occur when bicarbonate in the blood is used as a buffer in the presence of excessive acid. For example, in lactic acidosis, diabetic ketoacidosis, or paracetamol overdose. Alternatively, it can be low as a result of being lost by the body, for example, in diarrhea. Metabolic alkalosis is a result of bicarbonate levels being too high. Here, carbon dioxide will either be normal or high to try and compensate. This can be caused by loss of acid from the digestive tract, for example, in vomiting, or from being lost via the kidneys, in heart failure, nephrotic syndrome, or with diuretic use. To help distinguish the cause of metabolic acidosis, it can be useful to calculate the anion gap, which is the difference between the positive cations and the negative anions in the blood. If the anion gap is raised, the metabolic acidosis is likely a result of excess acid, as opposed to loss of bicarbonate. Mud piles is a useful mnemonic to help remember the causes of a raised anion gap. Feel free to pause the video and have a look at these. They're all conditions that result in excess acid in the blood. Finally, base excess is a combination of metabolites, but should closely mimic bicarbonate levels. So, to summarise how we interpret the ABG, we start with pH. We need to ask, is the blood acidic, normal, or alkalotic? Next, we look at oxygen. Is it low enough to diagnose respiratory failure, i.e. is it below 8 kilopascals? If so, is it type 1 with normal carbon dioxide, or type 2 with raised carbon dioxide? Finally, we need to properly assess carbon dioxide and bicarbonate levels to establish whether it's a respiratory or metabolic derangement. If the carbon dioxide matches the pattern of the pH, it's likely a respiratory cause. If the bicarbonate matches the pH, it's a metabolic cause. We can also assess whether there is any compensation from either carbon dioxide or the bicarbonate. As a caveat, it's important to be aware that some conditions can result in a mixed metabolic respiratory picture. For example, salicylate overdose can cause metabolic acidosis through excessive acid and respiratory alkalosis through hyperventilation. So, if an ABG result doesn't seem to make sense to you, it's worth considering, is this a mixed picture? Please consider subscribing and liking the video if you found it useful. It helps my channel out massively, and it means I can continue to make free educational content for you all. Thanks for watching, and see you next time.